The first thing I wanted to let you know is we are recording the session today, so please don't include any confidential patient health information during our discussion, particularly if you're discussing any cases specific. Let's see, so you also have information on your screen now on how to join audio. If you do have a camera, it looks like maybe Holly, we don't have that possibility at this point for you. You and I can always talk. I'm the systems analyst here and deal with all the IT technical issues. So if you need any help with that, I can help or work with you or work with your IT group and be able to get you on camera as well as some kind of a microphone. You do have the option of using the telephone to listen to and speak to the audio. So that's a possibility. If you hover over your little microphone that probably says mute right now, there's an arrow that's either up or down depending on its orientation, and you can choose to go ahead and disconnect and then reconnect to audio using your telephone. So that is a possibility. And if you do wish to receive CME and CEU attendance certification, you do need to let us know that you're out there and where you're from. Looks like we do have the two of you on at this point, and possibly looks like Linda Summers may also be joining us. All right, we're promoting you to a panelist, and so you'll have a little more control here in just a moment, Linda. All righty, and moving on. So I have the three of you on our list. Our disclosure and accreditation statements are on screen now. And so if you haven't announced yourself, let's see, I believe it was Linda, can also either chat in, or if you have a microphone, go ahead and unmute and let us know who you are, where you're from, and just as a matter of introduction.
Yeah, I'm Dr. Linda Summers, and I'm a nurse practitioner. I work at Ben Archer School-Based Health Center, and I've been involved with this asthma program for about 4 years.
Okay. Welcome, doctor.
Hi, Lynette.
Okay, and without further ado, looks like we have the three of you on. I will hand it over to Brandon Bell, who will introduce our speaker for today.
Hi, I'm Brandon Bell. I'm a quality improvement specialist here with Envision New Mexico. I've been working on asthma since I started here. I'm happy to introduce Kathy Moseley today. She is a nurse, a certified asthma educator, and regional project director for the Enhancing Care for Children with Asthma project, supported by the American Lung Association. The project is now in its 6th year. Envision and the American Lung Association have partnered to support several clinic groups, including Rehoboth-McKinley County, Rehoboth-McKinley Christian Healthcare Services in the current 5th group of Enhancing Care clinics. Without further ado, Kathy Moseley.
Okay. So we are here today because one of the clinic participants asked if we would review national asthma guidelines on severity, classification, and control. Rehoboth staff would like to standardize a little bit more their approach. So I'm glad this will be recorded so that staff, maybe even at Ben Archer, could use this as a tool just to review severity and control classification. Next slide. Oh, I've got it here. One of the items that Envision requested was that we start out with 3 questions. So I put 3 very basic questions up there regarding guideline, severity, and control classification. So the first one, these 3 questions many of you might already be able to answer, but if not, we'll review those and you should be able to answer them by the end of our session today. What are the 4 severity classifications specified in the 2007 guidelines? What are the 3 control levels? and what are the age groups for which severity and control classification differ. So just to review, the the 2007 guidelines had some major differences between previous versions. And one of those was that they added age categories. So as we go through the tables, you will see that the age categories, question number 3, have different criteria for 0 to 4, 5 to 11, or 12 and greater. The second major difference between this version of the guidelines and earlier ones is that severity classification includes 2 domains, impairment, which is basically symptoms, and a risk category. And then third, control rating is used in these guidelines to adjust medication. There are also 6 treatment steps in these guidelines. Okay. And I've put the references there so you can actually click and go to those tables if you want to look more specifically. So answers to question 1 and 2. Severity classification in these guidelines include 4 categories: intermittent, mild persistent, moderate persistent, and severe persistent. And for control, there is well controlled, not well controlled, and very poorly controlled. And here's an example of the 12 and over table directly from the guidelines so that you can see where those different criteria come into play. The rule of 2s is very helpful here to simplify this, what looks kind of complex. You can see that in the intermittent category, if you have symptoms greater than 2 times a week, or nighttime awakenings greater than or equal to 2 times a month, or use albuterol greater than, if it's more than 2, you go to persistent. If it's 2, equal to, or less, then you're in the intermittent category. So that helps differentiate intermittent from persistent. And the reason that's important really is that once you're in persistent, you graduate to using an inhaled corticosteroid. And the other items that we mentioned on this table, you can see we talked about having these guidelines emphasizing impairment and risk. So you can see the impairment category, and which includes symptoms, use of albuterol, nighttime awakenings, activity level, and lung function. And you can also see risk as a category, which means how many exacerbations requiring oral systemic corticosteroids did the individual have in the last year. And then at the bottom, you can see that the category of asthma severity correlates with a medication step. So for example, the intermittent group, and again meaning symptoms less than or equal to 2 times a week, for example, would be in the step 1 category, and that would mean just use of a quick reliever like albuterol. Okay, so that's kind of an overview. I wanted to show you that there are several tools you could use. Again, the guidelines, like I just showed you, has tables. The Council on Asthma has a 1-pager decision support tool, and I think I have an example of that that's laminated, and it's got the stepwise medications you can see in colored sections so that it's by age group, by color for each step, each of the 6 steps. That's another tool that's available to you, and if you're interested, I can send you a copy of that electronically. And another tool is one that is most popular with folks, which is the Quick Reference Guide Decision Support Tool. That is available online, and I have the reference there for it. And that you can download and print off yourself. And I know some of the clinics in this group are using that as part of their template for reference. So comparing that to the table in the electronic version of the guidelines, you can see it has some of the same things. You can see it online here. I guess I don't need to show you visually, but you can see that it has also intermittent and then the 3 persistent categories at the top. And on the side, you can see again impairment and risk. And then within each category, classification category, the age groups are also divided up in this one. So it's also a really nice one-pager view of severity classification. This is a stepwise approach for managing asthma in children 0 to 4, and it kind of breaks it out in a black and white version, so it's kind of clear and simple to look at. And the intermittent asthma, as you can see, again, that's symptoms, daytime symptoms, equal to or less than 2 times a week, use of albuterol, less than or equal to 2 times a week, and nighttime symptoms. So this shows that step 1 would be albuterol as needed. Okay, and again, once you graduate to persistent, that means a low-dose inhaled corticosteroid is the preferred treatment. And then additional treatments you can see in each of the steps. Okay. And again, talking about the emphasis on age groups, in the 2007 version, you can see that each, this is the table for 5 to 11, and it's just a little bit different than the 0 to 4. And then there's a stepwise approach for those 12 years and older, which also is has a few differences, especially in the 2nd and 3rd group, or 2nd and 3rd steps. Okay. And again, this is the one-page tool that the council uses, which has those differences color-coded for age. And this is the stepwise version within the quick reference tool. And you can see there that it has it divided into the 3 age groups for each step. Now, severity, then, treatment is based on severity. And we see here treatment or intermittent and persistent with the different steps. And I think I just need to explain that you want to use the step, the treatment step that is coordinated with that particular category, and then adjust so that the lowest level of treatment required to maintain control is used to minimize side effects. That's what that lowest level means. You always want to start with the level that will get the person under control, but then the goal of severity and control is to adjust medications so you're using the lowest level possible. So again, the goal of once a patient is classified with severity, then for follow-up appointments, you want to evaluate control. And the reason we do that is to adjust medications to minimize side effects. And control also is evaluated based on impairment or symptoms, risk or exacerbations requiring oral corticosteroids, and the categories, again, are well controlled, not well controlled, and very poorly controlled. And this is a table showing a asthma control table from simplified from the guidelines. And you can see within each category, again, there are differences according to age group. It also uses impairment category and a risk category, just like classification of severity. And then it is also paired with a treatment step. Oops. jumped. So one of the purposes for today was to go through some, use these tools on some examples and make sure that we're clear on all the different criteria. So I have attached electronically for those participating the quick reference guidelines. And so we're going to use those and table 5 to go through these. Oh, jumped already to case 2. Let me go back to case 1. Oops.
Is that what you wanted
Yes.
up there?
But I want to pull the case 1 up so we can just go over the, and I'm going to go back one. There we go. There we go. So this first case illustrates classification of severity because there are no medications involved. So we're seeing someone who has no long-term controller meds, and that means we're going to evaluate severity. And so we have a 13-year-old, and the impairments are daytime symptoms 4 times a week. So remember how we talked about if it's greater than 2 times a week, that immediately puts you up into persistent. But the question is, which category in persistent? So, and then nighttime symptoms 4 times a month, use of albuterol or SABA, short-acting beta agonist, I think was daily, no lung function test done, activity doesn't want to go to the gym, that's their limitation, and there are no risks involved or risk symptoms, in other words, no exacerbations requiring steroids. So now if Kevin can take us over to the table. So we talked about 4 times a week. That would put this person in the mild category up there at the very top, top row. Oh, thank you. So 2 times a week, or 4 times a week, so more than 2, but not daily. So that's mild category. And then we said 4 times a month for nighttime awakenings for a 13-year-old. So we're still in the mild category in that second row. But when we go to short-acting beta agonist or albuterol, we see that the symptoms were daily, which puts you up in the moderate category. And this example points out that you want to pick the category of symptoms that is the highest, so that you're picking the step level at the bottom that will address the most severe symptom. So the aim is to get the person under control. So in this category, if you go down the persistent, and remember we had no exacerbation, so we have no risk factors to consider. And the activity level doesn't want to go to the gym, which probably is either minor or some. So the most severe category would be the use of SABA, which is daily, and if you go down that column, it would be step 3. So then you go to the stepwise table and look under there. So that's case 1. Let's go back to case 2. And you'll let me know if anybody has any questions, Kevin, if they chat.
I will. Yes, I am monitoring that.
So let's go to case. Did I do that? Whoop. There we go. So case 2 again is no long-term controller meds. So maybe I can ask Holly. Holly, would this be looking at severity or control? I'll give her time to answer.
And she's stating severity.
Severity, no meds. And then we're looking at impairment of 2 times a week, 2 times a month for nighttime awakenings, 2 times a week for albuterol use. Okay, so, and then if you go to the first column, and we're thinking of the rule of twos, and these are equal to 2 times a week, nighttime awake 2 times a month, SABA use 2 times a week, no lung function, no limitations. However, there's a hooker thrown in this one, and this might bring up one of Holly's questions, which is the risk is 2 exacerbations in the last 6 months, one being an ICU admission. So everything, all the symptoms and the activity would put this person in the intermittent category, right? But Holly, what would it do when we throw in 2 exacerbations, one being in the ICU? What category would you put of classification of severity would you put this person in? This might bring up her question, I think.
Severe persistent is what she's responded with.
Okay, so that's what I would say too, and I think that kind of brings up your question about that risk level being a continuum arrow, and the mild category for risk is greater than 2 per year. This is only 2, but one of them is an ICU admission, which when you look at the categorization of asthma exacerbations, an ICU admission is higher than severe. It would be in the life-threatening category. So I would agree it would put you way up at the top here in severe. And that's even though all the impairment symptom or impairment categories might put you in intermittent. So that's case 2. Case 3 is an 8-year-old, and now we have a child who's on medication. Okay, so what do we do with that? Okay, he's already on medication, and if you look at the dose, he would be on step 4. Okay, so step 4 is what you would prescribe for what level of severity, Holly? Or Lynette, either one. Step 4 would be what level of severity classification?
And Holly says severe persistent.
Right. So now the question is, we already know, we can kind of back extrapolate from the medication what the severity of the classification might be. And we're going to use control classification to understand, is that level of medication working well, and how would we change it, okay? Or how would we adjust it to make sure that the person is on the minimum amount of medication they need to stay controlled so we can minimize the side effects. So we have, we go to control table, which is page 6 in that quick reference guideline. And we look at, okay, on medication, this person has symptoms one time a week. So that's less than 2. So that means well controlled. And this is an 8-year-old. So we have to look in the middle column of well controlled. 1 time per month, okay, and we're still in the middle column, well controlled. Albuterol use 1 time per week, okay, so we're still in well controlled. Lung function greater than 80%, okay, and we're still in well controlled on this step 4 medication. And there's no activity limitations and no exacerbations in the risk category. So how would you classify that control? Anybody? I know it's pretty straightforward. So it would be severe, persistent, like Holly said, and well-controlled.
Well-controlled.
Okay. So let's go to case 4 and then, whoop. Case 4. Okay, so now we have a 25-year-old. So we have an adult. We'll be looking at the older than 12 table. We have step 3, which is can be in an adult, would be step 3 would be a low dose ICS plus a LABA or a medium dose. Okay, and then we're going to look at, okay, they're on medication at step 3. That would be moderate, persistent, and how well controlled are they on that medication? We have daytime symptoms, 3 times per week, 3 times per week waking up at night. This is greater than 2, right? When we're looking at the control classification. Albuterol use is 3 times a week, so we are in the middle column, which is not well controlled.
That's what Holly says as well.
Okay.
She does have a question here.
Now there's ACT of 18, which is also in that not well controlled column. And the question was?
And the question from a little bit before. So severity can be extrapolated for a patient on medication by their medication level and control.
I think you have to be careful because you don't know what that person diagnosed the patient with, but I think that's a reasonable way to approach it until you have more experience with that person yourself. Does that make sense? Does that make sense to you? Would you agree, Lynette?
Holly says yes.
Okay. Okay, so that's case 4, and now maybe we can go to...
Yes, I can. I do.
You agree? Okay. So let's go to Holly's case, and Lynette can help here, I think. I need to move it. Okay, whoop, whoop. I must be pushing the bottom button a little.
I'm not sure what that is here.
There we go. So here is our a very practical example, and I'll go. I don't know if I need to read it, but at least if I read it, we'll know that everybody else has a chance time-wise. So this is a 6-year-old patient with asthma being seen for the first time for follow-up on an asthma exacerbation a month ago, for which she was given Duoneb. And Duoneb, and please confirm with me, but Duoneb is ipratropium and albuterol. So we're using now some adjunct therapy in treating the exacerbation. And the treatment is in clinic, and no steroids were prescribed at that visit. An established patient in the practice was seen by numerous times by other providers. And I clarified with Holly that she meant that this meant not necessarily for, she might not be familiar with what happened in those visits, right? Oh, can you read for us?
Yes, correct.
And per the mom, the patient started wheezing at about a year of age. She's had no hospitalizations or ED visits in the past year for asthma, although it's kind of a question what occurred with those numerous times seen by other providers in clinic. Mom reports that once a year she has required home oxygen and has exacerbations 4 times a year. And we may need to know more about the severity of those exacerbations. Currently, she's using her Ventolin, her albuterol, more than twice a week, during the day, but not daily. Okay. So if she's on medication and we're looking at control, let's see, is there a, there's not a, I don't see that it's named there, but if we're looking at control in light of patient that is on medication and she's using her albuterol more than twice a week but not daily, then we're persistent, mild persistent. Is that, do you agree, Holly? Is that what you would have classified her control as? I have to get farther maybe too.
Control would not be well controlled.
Okay, good. Middle column. Okay. Nighttime use less than twice a month. Okay. Her only known trigger is illness per mom's report. So, meaning that she might not have an allergic component.
And she also states, Holly does, severity based on control and medication.
Severity based on control or medication? Control or medication?
Control and medication.
Control and medication. Okay. Let's see. Mom states that she has had no, it looks like we're missing something there. What are we missing? Mom states that she has had no, does she say, does Holly say?
She doesn't remember.
Okay. And we have our current meds, which is Flovent, 110 micrograms per puff twice a day. And when I look up that medication category, that's a medium dose. Is that right, Lynette and Holly? Medium dose, right? She's also on Singulair. So she's on, if you look at medication steps for a 6-year-old, and you look at someone who's on medium dose ICS plus a leukotriene receptor antagonist like Singulair, that would put the 6-year-old in step 4 by my calculations. Is you two agree? Would be step 4. And it looks like Nod, Zyrtec,
Yes, agree. From Holly.
and albuterol. Agree. Okay, so this is step 4. Classified as moderate persistent. Okay, so if we go to moderate persistent severity, that would be step 3. She's he or she's being treated with step 4. So maybe it could be a severe asthma, or it could be that you're treating moderate asthma and treating it with step 4. Okay. So then when you saw her, given that she's not well controlled and moderate persistent, not well controlled, you did not change meds, but filled in education caps. Didn't have an inhaler with a spacer, so you're looking at one of the things I would ask is, okay, she's not well controlled, and the first item would be, is the person using their medication, right? And how confident were you that this child was using medication? She can answer that for us.
Pretty confident.
Pretty confident. Okay. So then your next step was technique. And so you, she didn't have an inhaler with a spacer and mask. So you must have provided that, gotten that, and taught her then it looks like. But you had certain questions that you'd like clarified about how to apply the guidelines in this case. So you felt like the classification by symptoms was clear, but the risk component on the table is just depicted with arrows, and you weren't sure how to interpret that. And I'm thinking in regards to this particular patient, because this particular patient had no hospitalizations or ED visits in the past year. This child, however, was seen numerous times by other providers, and also says that at home they had 4 exacerbations. And maybe you can provide us with a little bit more detail about what if the patient seen with the other providers, if those were for exacerbations treated in the clinic. That would be one of my questions. Are there more exacerbations than we're seeing, in other words? She had no hospitalizations or ED visits, but the risk portion says asthma exacerbations requiring oral steroids. Is it possible she could have gotten those in the clinic and treated?
So far she said not more than 4 times per year.
In the clinic?
I think she had oral steroids once in the past year.
Once, okay. So oral steroids once in the past year. If we go to control. That in itself would still be 0 to 1 per year, would be well controlled, but she's already not well controlled because of symptoms. So the highest thing would be not well controlled. Now, I guess one of your questions, I think, is if you're judging risk based on how many times a person had an exacerbation that was treated with oral corticosteroids, you're saying it's not clear to you that people use oral corticosteroids in the same standardized way.
And possibly to clarify that question, exacerbations not requiring oral steroids do not affect risk at all. Sounded like that was related.
Right, right. According to, that's how I read the risk section. But of course, I think as a practitioner, you'd want to use some judgment there if they had 5 or 6. But that's how I read it too. Now, my only caution there is, and I think this might get to your question, is when people treat, when practitioners are treating someone with exacerbations, and we're using the use of oral corticosteroids as a marker, are they prescribing them consistently with guidelines? So I see my role as trying to provide tools that as providers you might be able to use to increase standardization. So I looked up the assessment of exacerbations and the protocol for treatment within the guidelines, and that's in section 5, and there's a whole section on treating asthma exacerbations. And one on this is on page 375, and I didn't include this table. This talks about very broad strokes of classifying severity of asthma's exacerbations. And it talks about treating mild exacerbations, which means maybe they are only short of breath when they're doing an exertional activity. And their use of albuterol relieves the symptoms right away. And you could possibly consider a short course of oral systemic corticosteroids. And then there's the moderate category, which usually is shortness of breath that limits a normal activity, okay? And if you're getting, and there's peak flows associated with these, but I realize that a lot of times you can't do a peak flow, that only 65% of people or something can do a peak flow given an exacerbation, so you might not have that information. But in that moderate level, it talks about usually requiring an office or ED visit, and that a moderate exacerbation uses oral systemic corticosteroids. And even then, symptoms may last for 1 or 2 days. So I guess the question would be, would it be helpful to your staff to use some of these tools in that section 5 so everybody is on board and they're prescribing corticosteroids, oral corticosteroids consistently, so that you can judge what that means better in the risk category? Is that something that would be helpful?
I think that would be very helpful, as well as documenting the exacerbation as mild, moderate, or severe.
Right. Okay. So maybe that's where our place of work can be.
Yes.
If that makes sense. And then there in that section, there's that table, which I think is a very simple table. And then there's another one, formal evaluation of asthma exacerbation severity in the urgent care or emergency care setting. And maybe your clinic is sometimes treating this particular patient almost in an urgent care way. If you're, for example, there's a table, figure 5-6, that looks at management of exacerbations, and it divides them by mild, moderate, and severe. And they're basically using peak flow. But you could also pair that with this other table, 2 other tables that talk about the severity classification, and look at, okay, how are we treating it, and are we treating it consistently with oral systemic corticosteroids appropriate to the category of exacerbation, which would help you decide better on the control level.
And Holly has added, I think we treat a lot of asthma patients on an urgent care basis.
Yeah, that's what I was wondering. So when I see these levels of management of asthma exacerbation based on severity, the ipratropium and SABA use, combined SABA use, really is for severe and in the emergency room. So it does sound like you're treating in that mode, kind of. And it pairs when you're using adjunct therapy, and this is where maybe Lynette can help. But if you're using that adjunct therapy of ipratropium, which is really designed for use in an emergency room, it looks like you're usually pairing that with oral corticosteroids. And so if, for example, you said that you thought this patient already had one exacerbation where they were treated with oral corticosteroids, and if you had treated according to this guideline, that would have been the second one, right? And with oral corticosteroids. So maybe that's a place to start.
We don't use duonebs unless they are failing on the albuterol. They said they've been puffing on it all morning, and then we, instead of giving them more albuterol, we'll give them a duoneb at the urgent care.
And do you consistently pair that with an oral corticosteroid if you have to use the duoneb?
We do. We give them prednisolone right there at the clinic. I mean, they take it right away. It's usually paired. But if they've not taken their inhaler at all, or don't have any, then we start with albuterol and then give them the oral, the liquid prednisolone
Okay.
at the time.
Okay.
And then we discharge them with some.
Okay. Will that help in your clinic to use some kind of tool like this, so you're diagnosing the level of severity and treating them consistently based on that level? I guess I'm saying this is a question for Holly. That would help your Rehoboth.
Oh, yes, I do believe that would be helpful.
Okay. And then your final question was, does use of albuterol as a pre-treatment for exercise count at all? And I would say when I look at the tool from the guidelines, that it really kind of takes that out right away in the definition. I mean, it's pretty clear. I didn't have to look within the guidelines or anything. When you look at the classification table, it says right there in that first column, SABA use for symptom control, not to prevent exercise-induced bronchospasm. So I think that answer is really clear right from the guide. So do those answer some of the, does that help with some of the ambiguity that you were feeling about classification and severity? And do you have some other questions that you can add to the discussion?
So far, Holly says, yes, it does. Answer the question.
Okay. Do you have anything you want to? Oh, go ahead.
But I think it is true that there is subjectivity in determining risk. And she did have a question before while you were talking. So it seems that there is a lot of subjectivity in determining risk.
Okay. It really helped me to take a look at the classifying severity of asthma exacerbations. This very simple one on page 375, just to keep that in the forefront for me, and how you might treat it and where oral systemic corticosteroids came from. That, you know, if it's just shortness of breath on some exertional activity, would be mild. Once it interferes with usual activity, that's moderate. And if you can't talk, if you're having trouble talking at rest, that's severe. And if you can't talk, then of course that's life-threatening.
And 375 would be in the full guidelines rather than the pocket version, right?
Right, it would be in the entire version. Okay. Any other comments, questions, anything you want to contribute to the discussion? And if this is recorded, you know, think of questions that, you know, other people might have that we could clarify. And if not, maybe we're done. Lynette, do you have a tool that you use for classifying the exacerbation? Do you go with, you know, do you classify it was a severe exacerbation, moderate?
Yeah, I have an app that helps me, and it's really easy. So, but most of the time, my biggest thing is not the difficult ones, because they're the ones that clearly have a problem. It's when they just come in for a cough, and they say they've had the cough for 2 weeks, and it's at night. Those are, and they've had the cough, and then their history is that they had bronchitis, but they're two, and so they keep telling you that they've had this cough regularly, and that then they had bronchitis. I think that they're frequently misdiagnosed asthma, but I can't be sure. At the time, their lungs sound perfect because it's not nighttime and they're not sleeping.
Holly was asking, Linda, what app are you using? You know? Oh, you're muted.
Just
I
one
can
sec.
look it up. I don't have my phone on me right now,
Okay.
but it's pretty easy. I think it's from the American Lung Association.
I know there's one that's like Asthma MD, and it's kind of blue and white, and it's for Apple. Is it one of those?
Yeah,
Is it that one?
Yes.
Okay.
Asthma MD.
Yeah, something like that. And I think I do have that on my computer. And if you just maybe Brendan can pull it up really quick. If you just look under apps, I think that one's a very popular one. I think if you just get the one table, it's free, but it's a kind of a teaser. And then for more in-depth, you have to pay for that one, right? You paid for that asthma app?
This
Yes.
one, it's free.
Yeah, I did.
This
But I don't
asthma-
think it was very much. It's like $2.99 or $3.99.
Oh, it's cheap.
Let me look at my phone.
Okay. Yeah, because we're recorded, and so that would be helpful for others.
Mhm. Asthma MD is free.
Asthma MD.
Asthmatic
That's
is.
what I think it is, Asthma ND.
And I think it's just, when you say free, I think it's just one of the tables that's free. And then if you want more,
Okay.
then I think as I recall.
Mhm.
But still, those are very clear, and they look like the guidelines.
So this app description says that it is a free app with no hidden or upgrade fees.
Oh, no, it's great.
So
Can I see what it looks like?
Sure, and it may be changed since we last downloaded. But
Asthma MD Mobile Breeze. It doesn't look like the one I remember.
Where's my phone?
Maybe he can pull up hers. And
I can't find my phone.
I remember when I first saw an app, this is the one I was thinking of, Stat Asthma NHLBI Guidelines. Stat Asthma NHLBI Guidelines. It comes up and you get but I think, at least when I looked this one up, it was only for Apple. So,
Oh, thank
but
you.
do you have yours, Lynette, handy?
I'm looking for it.
So there are several.
So maybe while we're waiting, I know Holly did have another question.
Yes.
So for example, I think this was relating back to the subjectivity determining risk point. For example, what severity level would a patient on mild persistent medication with 2 severe exacerbations in the past year versus 2 mild exacerbations in the past year? So
Okay.
2 severe versus 2 mild.
2 severe versus 2 mild. And are we looking at severity?
What severity level patient on mild persistent medication?
Mild persistent medication. So mild persistent medication for mild persistent would be low dose inhaled corticosteroid. So you're saying there's a patient with who's using a low dose inhaled corticosteroid, and you're asking what impact it would be if they were
What severity level would a patient be?
they had 2 mild persistent, had 2 or more than 2. So it looks like I'm looking at the severity classification, and equal to 2 would still be mild, but greater than 2 would put them up in the moderate. Is that what is that?
Oh, yeah.
So if they had 2, they could still have a low dose inhaled corticosteroid. But if it's more than 2, that would bump them up to moderate and a medium, step 3, or maybe a medium dose.
And I think, and what might be differentiating here, in Holly's language, it's 2 severe exasperations versus 2 mild exasperations.
Oh, okay.
Okay, and she just said, okay, so 3 mild exasperations would be moderate. What about 3 severe exasperations? Where is that?
Good.
Well, I'm not a practitioner, but I'm going to look at guidelines and just say what I would think from looking at the guidelines. And it says generally more frequent and intense events indicate greater severity. So if 3 would be put you in moderate persistent, and if they were 3 severe, I might move it up to severe. And make sure that I was using a treatment step that got them under control, because that is the spirit of it, or the intent of it, is to make sure that you are getting control right away. In other words, and Lynette helped me here, but I think the idea is that you're not being conservative, you're getting it under control right away. And then you can reevaluate and back off.
So the one I use is asthma point of care.
Oh, okay.
It's
Asthma?
clinical decision support tool.
Asthma point of care.
But they're all the same. It's just to have something that when you're needing to look.
Yes. Is there anything in particular about that one that you think is a plus or a minus?
No, it's just
Okay.
the one I started using. I liked it. And I have a lot of tools, but I hardly ever look at it because I sort of know asthma.
Yeah. That's good to have a recommendation, though. So we had asthma point of care that Lynette uses, and then there was the stat asthma
Stat asthma.
that's designed for, I think that's the one that's designed for.
That's the NHLBI one.
And that's NHLBI. That probably, hopefully they all are. But, and then you found another one.
Oh, the asthma MD that we thought was the one that she used.
Yeah. And then asthma MD. So those are 3.
And I'm showing that asthma point of care, at least the one that I'm looking at, seems to be free.
Asthma point of care seems to be free. Okay. So getting back to Holly's question that I wanted Lynette to comment on, let's see, which was, oh yes, something, if they had 3 exacerbations that were severe, how would I interpret this continuum? And what I was saying was that the intent of the guidelines, as I understand it, is to start with the highest appropriate dose of medication that gets the asthma under control, and then to reevaluate. And so if 2 would put them in mild, and 3 would put them in moderate persistent, 3 exacerbations, but the 3 exacerbations are severe, then I would tend to treat them with the severe level step, put them in 3. But I'm not a practitioner, so I asked Lynette's help there.
I would too. I would treat them with the severe and then make sure they come back really fast so that we can not keep them on it like for a year or 2, make a lot of appointments. I have to go now.
Thank you very much.
No problem. Bye. Thank you.
Uh-huh.
And Holly also just said that is helpful, Kathy, and what I would be inclined to do in clinic.
Okay. Thanks for that, Holly. Okay. If no other questions, then we can close and we can share this with maybe the other staff that you wanted to reach.